Welcome to Conversations That Matter. Today, Mike, we have a very interesting guest from the U.S. military.
That's right, Stu. Today we have retired Colonel Elspeth Ritchie. She was the mental health advisor to the U.S. Surgeon General, world-renowned expert on PTSD, post-traumatic stress disorder, which we're finding in alarming numbers both in the U.S. and Canadian forces. It's estimated, according to the military services in Canada, that 1/6 of our current military are struggling with some sort of mental health issue. That's about the same as the general population, but of course there are unique factors to consider when we're looking at the military. Number one, experts like Dr. Ritchie say in the military, time to treatment is so key, and oftentimes because members of the military are out serving in the field, they may not be getting the treatment that they need as quickly as they need it. Veterans who are no longer in the military, harder to get to. And then of course there's stigma anyway around mental health in society, but in the military it's even more pronounced. And so we see people like Dr. Ritchie and counterparts in Canada trying to develop programs that help get the culture within the military wrapped around the notion of when you need help, ask for it immediately, and don't feel bad about asking for help, because the sooner that we can help, the better. And as she talks about in the interview, a whole new host and an innovative set of tools that psychiatrists and mental health providers are using with members of the military to address PTSD.
I know, I found it fascinating that there's this holistic approach to dealing with people who are suffering from what is classified as a mental disorder. It's not, on the continuum of mental disorders, it's not necessarily debilitating, but still you wind up finding yourself having challenges getting through your day-to-day experience. And so she's saying there's a whole range of options that are available to people.
Really, this is a significant issue, and that the best way, as with any mental health issue, is to look at the whole person. It's not just a prescription. And so Dr. Elspeth Ritchie is traveling the world now as a retired military person, espousing this new and better way of treating people.
And one of the things that she encourages anybody who is close to, whether it's a working relationship, family relationship, to somebody who could be a potential, trauma victim, talk to them. Open lines of communication.
That's right.
With that, let's go to that conversation. First of all, welcome.
Thank you. It's a pleasure to be here.
PTSD, what exactly is it?
So PTSD stands for post-traumatic stress disorder, and it's one of the psychological effects of war. There is particular diagnostic criteria that you have to get PTSD. But I'll tell you, there's a lot of stuff that people suffer from that isn't quite PTSD but related. So technically, to have PTSD, you have to have had trauma, and as a result of the trauma, you relive the event, maybe flashbacks or intrusive thoughts. You have numbing and avoidance. You don't want to go near something that reminds you of it, or you don't want to go and talk to people about it. And then you have what's called hypervigilance. That's when you're jumping and looking all around and scanning to see if something might be a roadside bomb or might be a sniper on a rooftop. And some of those are adaptive to being in combat. You want to be hypervigilant.
Mm-hmm. It's called survival.
It's called survival. But the challenge is when people come back from combat and they get back here and they don't want to get out into the world because it frightens them. They startle easily. They think that people are out to get them. And what's even worse, but not talked about as much, is that they get angry and irritable, and they get irritable at their wives and their spouses and their mothers, and that causes a lot of relationship problems.
So is it a mental disorder?
Yes, it is a mental disorder, although I will tell you there is some controversy about whether or not it should be called a disorder or an injury.
Right. The American military special operations, as I understand it, are reluctant to call it a disorder. Why is that?
Disorder implies that there's something wrong with you, while injury a broken leg, anybody can get an injury. This gets complicated though because some of the advocates worry that if you call it an injury and therefore the implication is that you'll get over it, then people won't be eligible for disability. So it becomes a very complicated discussion, not simply what's in a name.
So you talk about it from the perspective of the military, but is it just the military?
No. We first called it PTSD after the end of the Vietnam War, and that was in combat veterans from Vietnam. But it's very clear that people can develop PTSD from a number of different traumatic events. Sexual assault causes PTSD in a lot of assault survivors. Disasters, 9/11, earthquakes can cause post-traumatic stress disorder. And there's a debate within the field as to what is the level of trauma sufficient to rise to being PTSD.
When I first was given the opportunity to have this interview with you, I was talking to a fellow who was reading an article in Russian, but it was about PTSD and its relationship to veterans after the Second World War. And what they were discovering is just the act of pointing your gun at somebody could bring it on. Not that you were shot at, but that you even had to shoot at somebody else. Are we,
Is that a sufficient traumatic event?
Yeah.
Well, I would say if you're in the Second World War, you're probably in a pretty nasty, dangerous place.
Yeah.
And it's hard to isolate just pointing your weapon at somebody. You're probably scared you're going to be shot at the same time. One point here to mention is that it has had different names through time. So World War I, shell shock, World War II, battle fatigue.
Yeah.
We've had a variety of different names, but what's clear is that war changes people. Now, it's not all for the bad. There's some growth, and you asked about names. Another term is post-traumatic growth. Do people mature? And I'd like to add one more name to the conversation. There's a concept of moral injury. And moral injury is being talked about more and more, and it's not a medical diagnosis, but kind of an existentialist crisis. And that is the shame and guilt from having killed, maybe killed children, is one thing that leads to it. Another is perhaps you've come back intact and your buddies are either dead or had their legs or their genitals blown off. Because remember, the blast is the signature weapon of the war, so a lot of people lose that part of their bodies. Or sometimes what happens is that the institution, the military, that they have identified with, for whatever reason, they're leaving, or if they're being discharged, or there's an investigation, and so they feel betrayed by the military. So all of these can lead to this moral injury concept. And one of the reasons I bring it up is it's so corrosive. Probably that is a much bigger factor in suicides than we know.
I'm a family member, I have a veteran who comes home, and now all of a sudden they're a little bit different. How do I, what are some practical things beyond saying, how are you doing? How do I start to reach out and create an environment that provides them with a bit of safety around starting to open up? Because I think that that's difficult.
It is difficult, and I challenge you that you want to have them open up to you. If that's a goal, then you may not get there if you're asking for a dramatic recital of what happened. So I'd say one of the things as a family member to do is educate yourself. There's a lot of good material on websites, the National Center for Post-Traumatic Stress Disorder or others, so you can learn a little bit about it, and then you may not have to have the conversation about what are you suffering from, but you simply, have the conversation about let's go to the grocery store or let's do something together. One thing I'd like to emphasize is that soldiers really like physical activities, and they really like group sports. They like kayaking and bungee jumping and whatever else. So it may be easier, rather than having the conversation, is to go do some traditional, playing ball. And that sounds simple, but it really helps in many cases. But also don't back off from the subject. If he or she is ready to share, that's a moment that you want to be there.
It's got to be challenging for the family, though.
Absolutely.
You've been away, now you come home, now you're not the same person that I fell in love with. you're not functioning properly. I still have my life. I still got, the kids, or we got to look after the mortgage, or whatever all those things are. And now all of a sudden I'm having to deal with this. How prevalent is it for the spouse to then start to pull away?
Well, that certainly is a problem, and it's a problem on both sides. Again, I said one of the hallmarks is numbing and avoidance. Another thing that's not talked about as much as it should is that often when service members come back, they may have problems with their sexual functioning, either because they're on medications that are used to treat PTSD that cause problems in some cases with sexual functioning, or they may have a traumatic brain injury. And if you're uncertain about your masculinity or femininity, that's going to have you pull back more. So again, there's a conversation to be had about that. I'm working on a book right now about sexual health and combat injury, and how do you discuss that really taboo area.
How do you?
Well,
Seeing as you brought it up.
first of all, it's something that perhaps there's many discussions. So there's a discussion with the doctor, and the doctor has to be willing to ask the question. And there's a discussion with a spouse, and that may be difficult to have one-on-one. That's actually part of the reason I'm writing the book, so that the spouse knows. For example, if somebody's put on one of the common antidepressants and I say antidepressant because it's used for PTSD, those are things like Zoloft and Paxil and Prozac are used very commonly that cause a sexual side effect. Well, if you don't know that your erectile dysfunction might be related to that, then that's a problem. But if you have learned that, hey, this is an issue, you could say, well, why don't you talk to your doctor about it? It may not be you, it may be the medication. And one of the areas I'm also interested in is alternative forms of treatment that don't cause sexual side effects. Let me go back for a moment, though, because you asked about how do you approach the soldier, and a lot of that depends on where you are. So if you're at a big base like Fort Hood or Fort Bragg, Fort Stewart, everybody's in this together. Everybody's coming and going. It's part of the normal life, and it's much easier to talk about it. You got family readiness groups. Where if you're a reservist and there's nobody around you who's in that setting, that's much harder. And there are, again, some resources on the website that people can go to. There also are, hopefully, more and more civilian providers, and I say hopefully because we're training them, that know how to start the conversation.
I understand it from a military perspective. It's a very real and present consequence of being engaged in war. When we come back into general society here in North America, who else is vulnerable?
Well, everybody is vulnerable, but our higher risk populations are those who have been sexually assaulted. We know that's very high risk. Those who have been around a major disaster. And more commonly, we know that growing up in a lot of poor neighborhoods with violence, guns, needles, such as not too far from here in East Vancouver, well, people are growing up there exposed to traumatic events. And usually people are adaptable. They adapt, but it definitely changes them and scars them, and that is often very difficult to get through.
On the continuum of mental health disorders, where does PTSD fall?
So many people have said, and I agree, PTSD is the common cold of psychiatry.
The common cold?
Yes, I mentioned a third of soldiers get PTSD, and it comes in a whole range of severity. And maybe common cold is slightly an understatement, but certainly some people, they have some symptoms, they go away on their own. Some people get some treatment, and in some cases it hardens into a chronic condition, like chronic bronchitis or pneumonia. In some cases it leads to suicide. Again, the analogy is not perfect, but one piece is that as early as possible, if you get treatment, the less likely it is to harden into the slide into substance abuse, unemployment, and homelessness.
Are we in Vancouver seeing greater or a growing number of signs of people suffering from PTSD as we have more and more veterans that are also serving in the Middle East?
It's hard for me to speak to Vancouver specifically, although I know that you're a magnet for many people because it's such a beautiful city. For the states, we've had 2.7 million veterans who have served in Iraq and Afghanistan, and when they come back, most of them do okay initially, but what we worry about is a slide into the homelessness, into the PTSD. And I think that what I've seen in my visit to Canada so far is you're a little bit, not behind us exactly, I don't want to use that term, but we've had many more service members who have deployed, so the problems really started surfacing in 2005. Our suicide rate started going up. 2007, we had the surge. So we have a little bit more knowledge. Although the flip side is, I think that your military, from what I've seen, is really on top of this. They're doing everything they can to identify and treat PTSD. But it's a problem that's too big for the military, at least in the U.S. It's too big for the military healthcare system. It's too big for the VA. It needs a national effort.
Let's say there is a mother of 2 children right now, and they're watching this program, and their husband is, or their partner is in the Middle East right now, engaging with ISIS. And they're looking at this and they're going, okay, well, what's the danger zone when they come back? How long is it? At what point should I start to intervene? What should they be looking at as far as the gestation of the symptoms starting to appear?
Well, before you go there, one of the things I'd emphasize is our soldiers are well trained now. It's different from Vietnam, where we had people who were, just drafted and sent over. And soldiers have what can be called stress inoculation preparation. So it's not exactly as if they're going to be unprepared. Having said that, they see a lot of trauma and repeated firefights, repeated deployments. Many people call it the new normal. But I wouldn't assume that they're going to come back and crack up. They're not human.
But you can understand
bombs.
that somebody could be worried about that.
They absolutely could be worried, as they could be worried about, having a police officer for a husband or any of the dangerous occupations. And I'm not dismissing that worry at all. So, your more specific question, how long does it take?
Yeah.
It can be months, it can be years, it can be decades. Many of the Vietnam veterans did fine until the Iraq-Afghani war started. Then they started getting triggered by the chopper blades, and that's when they had symptoms. And PTSD is kind of a unique disorder in that it can be triggered by smells and sounds and sights. The recent movie, American Sniper, a lot of people ask me, should I go see it? Will my PTSD be triggered? I went and saw it, and I thought it was a very good movie, but certainly going to see that, it takes you back to Fallujah, and that can be fairly powerful. I think maybe the more important part of the conversation is not so much when will symptoms emerge, but what do I do if they do emerge? And that comes back to the beginning of the conversation, how do I talk to the veteran if the symptoms are there? One of the things is just accept some of them are going to be normal. If your veteran hits the floor when the firecrackers go off, okay. And the veterans themselves will joke about it. There is a tremendous sense of community among veterans, and so there's a lot of peer outreach. And if another thing you can do is, if you're concerned about the veteran, what is the appropriate community that he can go and talk to? And even if he's not talking to me as mom, at least he's sharing his experiences with other folks there.
So I guess the most important thing is, how well are we doing at helping these people who are affected with PTSD get through it?
Not well enough.
Really? What can we do better?
Well, I think there's a few things that we can do better, and this is what's exciting about coming up and being here, is to talk about it. I will say that there's not a silver bullet. We're not going to be able to say there will be no more suicides. We tried that in the Army. didn't work.
Right.
Suicide's a very complex phenomena. I think the first thing we can do is having exactly this conversation here, and other conversations where we're talking about it openly. We can talk about it in schools. Many veterans go back to school and there's no support for them. They're older than their colleagues. They suffer from ADHD, PTSD. They can't concentrate. So I'd urge anybody who is part of a school to say, do I have a veteran support organization in my school? Employment is incredibly important. I've long said the best mental health intervention is a good job. It gives people structure, a sense of meaning, and of purpose. We can look at the homelessness situation. The United States, the VA, has said we're going to end veterans' homelessness in 5 years. I think that's a little ambitious, but it's a good, lofty goal to start to get to.
So where do we go from here? What do the next 5 years look like?
I think the next 5 years are increased conversation. And again, I come back to conversation because awareness is so critically important. There are many barriers to care right now. People don't want to go into a mental health clinic with that name on the door. So I'm a big believer in integrating primary care and mental health care, having all providers ask the question, have you served in the military? Are you a veteran? And then when you get the answer yes, then go down the road of asking more about the military experiences first. Don't go right for the PTSD. Somebody will clam up and leave.
Yeah.
But, respect somebody for their service. So have the medical community be more on top of what's going on. And then there's a concept of gatekeepers. Gatekeepers are police, firefighters, defense attorneys, people who, when somebody may get in trouble, they go there. That's another population that you really want to educate about the psychological effects of combat. And then finally, come up with treatments that are attractive to soldiers and work. And there's a lot of efforts done in that area right now. If you have treatment, but the soldier won't go to treatment,
Because of stigma or whatever other
or
reason.
we don't. I don't like the sexual side effects of the medication. I don't like
Mm-hmm.
talking about what happened. I'll tell you, Stu, one of my favorite treatments, and I'll use this as an example. There's a lot of new treatments coming along. One of my favorites is working with dogs. It's called animal-assisted therapy. We sent dogs to Iraq, and they work with the combat stress control teams. Sergeant Bo and Sergeant Budge, Sergeant Zeke were the dogs. And so people who didn't want to come and see me would, come over, pet the dog, and that would lead to some therapeutic alliance, some trust building. There's a lot more research that does need to be done, though. The U.S. military is devoting hundreds of millions of dollars to the study of PTSD and traumatic brain injury. A good thing about that is that the discoveries there are going to help everybody. Battlefield medicine usually leads the way, both in surgery and psychiatry, and I think what we learn about curing the stresses of warfare is going to help everybody.
I wish you all the best as you do this work, because there are so many people that will benefit from it. Thank you very much for joining me.
Thank you, Stu.